evening, everybody. We welcome you all to the educational series of innovations in hematology. And today our focus will be on lab hematology. With the advances happening and the introduction of genomics into the classification, the challenges are increasing. And to solve this conundrum, no better way to listen to the expert herself. And I will request Dr. Rahul Bhargav sir, who is our Principal Director and Chairman of Hematology, to please introduce our speaker.
And thank you, Dr. Asta, and thank you. Welcome to all the participants, around 400 plus participants across 40 countries. It's my pleasure to introduce Dr. Sanam Logavi. She doesn't need any introduction. She is the powerhouse of hematology and a leading force for understanding hematological malignancies across the world and working as an associate professor in MD Anderson right now. She has got a huge experience in hematological malignancies, and she's a board certified hematopathologist and molecular pathologist, specializes in hematological malignancies, particularly myeloid neoplasm, which has actually taken our interest also right now at this present moment in the country, because still a lot of things which are happening new in the field of hematological malignancies, whether there be KIT mutation, the newfound love, Dr. Sanam, for us as a Department of Hematology is c-KIT mutation, which continues to evade us and continues to have relapses even 2.5 years down the line. Her research includes molecular risk stratification of hematological neoplasms and MRD detection by flow, which again is somewhat controversial, but we would like to hear sometimes. We have been debating quite a lot with Dr. Asta about the role of MRD by flow versus NGS, and Srinidhi is working on MRD NGS, and Dr. Asta is working on MRD flow. So one day we're going to have the tug of war between two and see who goes and wins out. She's the medical director at Econ Akron Leukemia Bank at the Central Repository and Pathology Facility at MD Anderson, authored more than 200 peer-reviewed journals, peer-reviewed publications focused on hematological malignancies. And we know the ASH Image Bank in American Society of Hematology meeting was a big hit this time, and a well-received one as well. So it's our honor to have Dr. Sanam here to understand the intricacies of what brought in the WHO and ICC and how it can help. We should not be calling a low middle income country, but the countries which are graduating from morphology to flow to genomics. That has been a journey for quite a lot for Indian perspective as well, which is like, just to keep you perspective, we are a country of 1.4 billion people, Dr. Sanam. And we tend to cater all across Middle East, Iraq, which is your big neighbor. Hugely Middle East people tends to travel to India for the treatment from Yemen, Syria, and so on and so forth. So it is still their unmet need, and through these webinars, if we can reach to the correct diagnosis and how we can give them the molecular classification and genetic classifications to these people, so that the hematological malignancies are no longer untreated and unconquered frontier. So you have achieved a significant milestone. We'll be happy in next 40 minutes to listen to your views, so that all of us can get benefited and we make a world a healthier place. So without wasting much of our time, to our delegates, and please keep your questions ready. You can ask your questions, send it on the chat box, and Dr. Sanam will be happy to answer those in next 20 minutes. And this is not the first and the last time. She is such a wonderful person. She'll continue to help us grow hematopathology till every person we can conquer suffering from blood cancers. Over to Dr. Sanam. Thanks a lot.
Thank you very much for that kind introduction and for having me. Really, I'm truly honored, and thank you to everyone for tuning in and listening to me. I hope that I can make the talk practical, and my goal is going to be while the classification really now revolves around the genetics of myeloid neoplasms, I hope that I can show you that there are still tools that we can use as surrogate markers, even in more resource limited settings, to try and really underpin the genetic abnormalities that are driving these neoplasms. So I think we still have a lot at our disposal as hematopathologists just by looking at morphology, doing immunohistochemistry. Of course, molecular studies, next generation sequencing are the gold standard. But I think that there's still a lot that we can do even without sequencing studies. So with that, I'm just going to jump right in. I'm going to share my screen with you, and we'll get the talk started. Oh, did I share the wrong screen, or did I? Sorry, I think I shared the wrong screen. Let me do that again. Okay, we want to share screen. Okay, do you see it? All right, perfect.
Yes, we can see.
Okay, so let's talk about the application of the WHO fifth and the ICC classification systems and the diagnosis of AML and MDS, actually, not MD. So, of course, you're all aware that there are two new well, relatively new. They're about 2 years old now. They're not, that new anymore. But the WHO fifth edition that was published in Leukemia in 2022 and the ICC, that was an inaugural introduction of this classification system, was also published in Blood in the same year. These papers came out in about a month apart. Both classifications really rely on genetic classification of myeloid neoplasms as much as possible. And really, you'll notice that the default theme in these classifications is to use the genetic pathogenesis of any kind of neoplasm to classify, unless there's no known pathogenesis that's molecularly or genetically driven, in which case we revert back to morphology again. I'll start with MDS. So the WHO classification, the blue tables are going to represent the WHO classification because of the blue book, and the purple tables that you're going to see are going to represent ICC. So the WHO fifth edition has really dramatically changed the classification of myelodysplastic syndromes, or what they call it now, myelodysplastic neoplasms, to emphasize the neoplastic nature of this disease. It's, I think it may be of interest to you to know that, when you talk about some of the, when you talk to some of the nursing staff and the coordinators that do the research and clinical studies, they were saying that sometimes they have trouble getting insurance to reimburse for some of the tests for myelodysplastic syndromes, because sometimes insurance companies don't recognize MDS as a cancer. Right? So the emphasis medically defined, it's broken down into 3 categories. One is MDS with isolated deletion 5q. Despite what the name implies, you're allowed to have more than one additional abnormality, but 7q or deletion 7 are not permitted, right? So as long as that abnormality is not chromosome 7 abnormality, you can have one additional abnormality and still qualify for MDS with delta 5q, and of course you can't have increased blasts. And then MDS with low blast and SF3B1 mutation. Here, obviously, as the name implies, you need an SF3B1 mutation. The WHO requires a variant allele frequency of 5% for the mutation to categorize the MDS in this classification. However, if you don't have SF3B1 mutation, but you have more than 15% ring sideroblasts, you can still lump those cases within MDS with ring sideroblasts. And the reason for this is that, in the original studies that were done with the drug luspatercept, it was well known that patients with increased ring sideroblasts respond better to luspatercept. Although now luspatercept is approved for any type of MDS, and at least in the United States by FDA, but really the emphasis here was to recognize the category of ring sideroblasts with MDS with ring sideroblasts, and of course MDS with what the WHO calls biallelic, but you may hear multi-hit in the ICC or other classifications, and I'll talk about this in depth, but this is a completely novel category, and we'll talk about it. Essentially, it means that you lost both functional copies of your TP53, right? So you need to lose both copies to fit into this category, and of course, you need to have less than 20% blast, because if you have more than 20% blast, you're AML. If you don't have any of these genetic abnormalities, then you revert back to morphologic classification, which is based on the blast count with the cutoffs that I've listed for you here. So the WHO still recognizes 2 subcategories for this. So increased blast 1 and increased blast 2, depending on the blast threshold. And then MDS with fibrosis. These cases typically also have increased blast. And remember that MDS with fibrosis is enriched for cases with TP53 mutation, but TP53 trumps fibrosis. So if you have both, you fit into TP53. And then hypoplastic MDS is also distinctly recognized because of the overlap with aplastic anemia and some of these patients responding better to immunosuppressive therapies. All right, so that's the WHO. In the ICC, the classification is very similar. I'll point out the subtle differences that exist in here. So for MDS with mutated SF3B1, the ICC requires a 10% variant allele frequency for SF3B1. They explicitly exclude RUNX1 mutations from this category because we know that RUNX1 mutated MDS has a worse prognosis. And they don't recognize the ring sideroblast as a distinct category if SF3B1 mutation is not present. So if you have ring sideroblast and no SF3B1 mutation in the ICC classification, you go into the MDS not otherwise specified category. Deletion 5q is the same, and MDS with mutated TP53, the definition is the same. You still need a multi-hit status. However, they cut off the blast here at 9%. Because if you have 10% or more blasts, then you're into this MDS/AML category that is exclusive to the ICC classification, and we'll talk about this a little bit more. Okay, so why do we care so much about the allelic status of TP53, what we just talked about? This is largely based on a paper that was published in Nature Medicine by Elsa Bernard, who was at the time at Memorial Sloan Kettering, and Elie Papa-Manuel, who is at Memorial Sloan Kettering now. Elsa has since moved to France. And really, when this is something, a fortuitous finding that stemmed from the IPSSM classification. When they were working on the IPSSM classification, they noticed that in their TP53 mutated MDS patients, the patients that had multi-hit TP53 status had both in terms of their hematologic parameters, so CBC, hemoglobin, platelets, neutrophils, and in terms of their outcome, meaning leukemia-free survival and overall survival, those patients had a poor prognosis, much poorer prognosis compared to the patients that had just one TP53 mutation. Really, the patients that had one TP53 mutation their disease behaved like wild-type TP53 status. So, let's think about this. Why is this? Let's try and make sense. The reason for this, I think, is actually very logical if you think about it, right? Because TP53 is a tumor suppressor gene. If we think about biology in general and oncogenesis, when the cancer is driven by tumor suppressor genes, like let's say RB1, TP53, you usually need to lose both functional copies. The body can, the one wild type copy can usually compensate and avoid that catastrophic event. Whereas in contrast, if your cancer is driven by an oncogene, let's say MYC, by amplification of MYC, you only need one bad copy, and that's going to drive the disease. So in this case, when we think about TP53, how do we define this multi-hit or biallelic status? I do want to point out to you that, in none of our clinical labs, even in the most sophisticated settings, are we doing single cell sequencing, right? So we really don't know if the two mutations, when we have two mutations, are in two different alleles or in two different clones. Most of this is just inferring and implying based on biology and based on what makes sense. But the way we define this now is if you have more than one mutation, we assume that the two mutations are in two different copies. If you have one mutation and your other copy is deleted, right, by way of deletion, which you can detect by karyotyping or FISH or other methods like optical genome mapping, then you also have multi-hit because you deleted one copy and the other copy is mutated. And then the tricky part is the copy neutral loss of heterozygosity. What do we mean by this? It means that you have one mutation and then your wild type copy is deleted and the mutated copy is duplicated. It's kind of like uniparental dichotomy, right? But what happens is you still have two copies if you look. So you're not going to detect this by FISH and you're not going to detect this by karyotyping. Really, you need specialized methods. Some NGS platforms can do this. Array CGH can do this. But if you don't have this in your laboratory, and many clinical labs don't, if you have a mutation with a variant allele frequency of more than 50%, you can assume that you have copy neutral loss of heterozygosity. So those are the three ways we get to multi-hit status. Okay, and then what about the blast count in this setting? You'll notice that the ICC lumped all cases with more than 10% blasts in the MDS/AML category, and then of course more than 20% is AML. The WHO still hasn't done this and doesn't recognize TP53 mutated AML as a distinct category. However, I do think that there's two important things to consider. One is in the TP53 mutated setting, especially in the multi-hit status, once you reach 5% and more blasts, really the outcome of these patients is similar. They all behave just as badly. And this is largely based on this GROP study that was originally published in 2022. And there are other studies that have, later corroborated these findings, is that patients with TP53 mutated AML and what at the time was considered MDS with excess blasts, meaning, MDS with more than 5% blasts, really these patients behave similarly in terms of their outcome, in terms of their hematologic parameters, in terms of the allelic status of TP53. And so, they kind of proposed that we should have this category of high-grade myeloid neoplasms with TP53 mutations. And I think really that is justified and it is fair because, again, these patients do really poorly. All right, what about SF3B1 mutated MDS? SF3B1 mutated MDS, it's a relatively young disease, right? We've known about this disease maybe just a little over 10 years. Of course, we've known about ring sideroblasts for much longer. The FAB even recognized ring sideroblasts. However, we know now that the genetic, the pathogenesis of the majority of ring sideroblasts is SF3B1 mutation. So how do these patients present? They have, typically their most profound cytopenia is anemia, although other cytopenias may occur. They may have single lineage dysplasia or multi-lineage dysplasia. Typically, you'll see erythroid predominance with, profound erythroid dysplasia. You may see left-shifted erythroid maturation. Ring sideroblasts are typically increased, but sometimes they're not. So it's not 100% foolproof. And if you think about the IWG criteria, the original IWG criteria that defined SF3B1 mutated MDS, you needed to have cytopenia, of course, for MDS. You needed to have a somatic SF3B1 mutation, present or absent ring sideroblasts and morphologic dysplasia, and less than 5% plasma in the bone marrow and 1% in the bone marrow. So really the definition is similar to what the ICC and the WHO are using, although at the time there was no BAF cutoff. Although I do think, and you'll see some studies hopefully soon from us, where we think the VAF cutoff really does have prognostic implications. Okay, so let's look at a patient example. So here we have a 60-year-old patient. You'll see that the absolute neutrophil count is fine. The patient hemoglobin is actually not that bad, 12.7. So for a woman, that's not even really considered that bad. And then MCV normal, but there is thrombocytopenia, right? The platelet count is 45. When we look at the bone marrow, there's megakaryocytic dysplasia. Here's a dysplastic megakaryocyte right here, some small megakaryocytes, like some hypolobated megakaryocytes. And then on the aspirate smear, you do see some erythroid left shift. Look at this, the left shifted normoblasts. There's also basophilic stippling here, some cytoplasmic fraying, some asynchronous maturation. So there's also erythroid dysplasia, right? So we did NGS on this. This patient also had 15% ring sideroblasts and 1% blasts, and SF3B1 mutation with a variant allele frequency of 23% and a DNMT3A splice site mutation. All right, so by, the SF3B1 mutation is 6% BAF. So by ICC, this patient would be classified as MDS-NOS with multilineage dysplasia because of the 6% BAF, right, cutoff. And by WHO, they would be considered SF3B1 mutated MDS. Now let's look at the risk stratification for this patient. So here I've given you the link for the IPSSM calculator. It's very easy to use. You can just put in the different parameters. There's CBC parameters, genetic parameters. And the good thing about this calculator is that you don't have to have all parameters to apply this. So you can miss some of the attributes and the calculator will still work. Of course, it won't be as perfect, but it'll still work. So when we apply the IPSSM calculator for this patient, the overall risk of leukemia-free survival, the length of leukemia-free survival predicted median is 5.9 years. And the AML transformation rate is 1.7 by year. This patient is considered low risk, okay? Now, in contrast, we have another patient who is 86, has a normal white count, slightly decreased hemoglobin, and a normal platelet count here, okay? Let's look at their bone marrow. They have multilineage dysplasia. You can see the megakaryocytic dysplasia in the middle. The granulocytes are hypogranular. There was patchy increase in blasts, about 4% overall, and 50% ring sideroblasts, right? And you can see the erythroid dysplasia here as well. This patient had a diploid karyotype. So now let's look at the NGS. In contrast to the other patient that only had a couple of mutations, one was SF3B1, this person also has an SF3B1 mutation, right? But now they have other mutations, including KRAS, U2AF1, IDH2, NF1, ASXL1. So let's apply the risk calculator for this patient. This patient is considered to be moderate high risk by IPSSM, and their leukemia-free survival is predicted to be 2.3 years, with a 9% risk of progression by year. So obviously the risk for this patient is not the same, right? Even though, let's say in the WHO, both patients are classified as SF3B1 mutated MDS, right? So I just want to highlight for you here that classification and risk stratification are not necessarily the same. And I think it is important, this may be one of the limitations where we say this may be only applied in resource rich settings or resourceful settings, but really this is important for patients. And what's important is, if you think about and you'll see some recent publications on IPSSM, really the power of IPSSM is in predicting who is going to need a transplant sooner, right? And preparing the patient for transplant. It's not necessarily to start HMA therapy sooner, right? Because we know that HMA really corrects the counts. It's not really correcting for the underlying genetics. So if the patient is not yet transfusion dependent, if they're not yet profoundly cytopenic, there's no benefit to starting HMA sooner, but there is a benefit to preparing the very high-risk patients for transplant, getting them HLA typed, finding a donor. So that is important. And, I think this is something that we as pathologists should be aware of, and obviously clinicians are going to use. Okay. So, we talked about the allelic status of P53. How do we, again, if you don't have sequencing, how can you, what's a surrogate that you can use? We talked about TP53 mutations. So P53 IHC is actually a very good surrogate marker for the presence of a TP53 mutation. It is agnostic of the allelic state. So it cannot tell you whether it's multi-hit or uni-hit, but it can tell you usually with relatively good confidence that there is a mutation. Two things I want to highlight. One is most labs have optimized their P53 IHC for GYN tumors, right? Like high-grade serous carcinoma, if you think about your labs. It's important that the P53 IHC be optimized for bone marrow. If you're going to use it for AML and MDS, you have to optimize the stain for bone marrow. That's one thing. The other thing is, the wild type or normal pattern, you're always going to see some 1+, 2+ staining in a subset of the cells, and that's normal because this is not a mutant-specific IHC. It just detects any P53, and the cells in our body have P53 protein. What happens is when you have a mutation, the mutant protein is resistant to MDM2-mediated degradation, and so you get accumulation of the protein. And so this this panel here is the mutant pattern where you see 3+ staining in a subset of the cells, and that is abnormal. The other mutant pattern is if you see completely negative staining. Here, if you look, the cells that are staining faintly here are the endothelial cells and the histiocytes. But the myeloid cells, the mononuclear cells, are dead negative, and that is abnormal, and it usually correlates with a nonsense or an early terminating frame shift mutation where the antibody doesn't recognize the protein at all, right? So that's also abnormal. There's a pitfall here, and the pitfall is sometimes you'll see some cases that have very high proliferation, usually correlating with signaling pathways like FLT pathway mutations like FLT3 or RAS pathway mutations. These will also have elevated levels of P53, but it's going to be in the range of 2+. It's not going to be in the range of 3+ staining. So one caveat to be aware of. Okay, so here's an example of a TP53 mutated MDS with biallelic TP53 loss per WHO and MDS with mutated TP53 by IHC. Again, we can see the morphologic dysplasia here on the aspirate smear. I don't think the erythroid dysplasia is subtle. You can see it's profoundly dysplastic. If we look at the karyotype, it's a complex karyotype. But if you look at the mutation here, so I'm not actually showing you the mutation here. There is no, there's no 17, there's one copy of 17 only, right? So there's loss of 17. And then also by P53, you're seeing this very brightly staining cells. So only, again, the 3+ counts, right? So there's a mutation here, and on NGS, there actually was a mutation here. Okay, so here's another example of a myeloid neoplasm with fibrosis and increased blasts. I want to, again, highlight the point that I made earlier, is that, you really don't need a reticulin to say that this bone marrow is fibrosis. You can see the cellular streaming, there's increased blast, but again, we do have the reticulin to kind of prove the point. Typically in these patients, the aspirate smears are very poor because the bone marrow is fibrosis, but I did find a few blasts here and there. And then you can see the P53 IHC is just very strongly positive. So this is a mutant pattern. So again, even though the patient has fibrosis, this case, by the presence of a P53 mutation with a variant allele frequency that is high, that is 16% and a complex karyotype with deletion 17p, qualifies for TP53 mutated MDS, right? So P53 mutation trumps fibrosis. Okay, what about AML? Again, AML is now largely classified by its genetics, and here are the different categories I've listed here for you. Some of these are not new, they were in the previous iteration. It's just that now the blast threshold has been removed for them, but NUP98 is a completely new category. Remember, NUP98 rearrangements are often cryptic, meaning the NUP98 is on chromosome 11p, but you're not typically going to see the deletion or the rearrangement on a karyotype. You need to do FISH or optical genome mapping or RNA fusion. But if you don't have any of those, if you have a leukemia, an AML, that has a FLT3 mutation, typically ITD, with concurrent WT1 mutations or CBPA mutations and no other driver, then you want to think about NUP98 rearrangements. The WHO has retained the 20% blast threshold for CBPA mutation and BCR-ABL1 translocation. Obviously, BCR-ABL is to prevent overlap from blast crisis of CML. And then we'll talk about AML myelodysplasia related, but the WHO, again, requires a 20% blast threshold here. For the ICC, the genetic categories are pretty much the same. The ICC requires a 10% blast threshold for all of the genetically defined AMLs. Other genetically defined cases, if you're in the without genetically defined, if you're in the 10 to 19% category, then you're considered MDS/AML. Okay, how about CEBPA mutations? So the definition of CEBPA AML with mutated CEBPA is changed, largely because there were studies that were published after the 2016 classification that showed that the good prognosis of AML with CEBPA is not only restricted to cases that have biallelic CEBPA mutation, really it's restricted to the cases that have a mutation, any in-frame or missense mutation in the BZIP region. The reason for the biallelic thing was that the majority of cases with biallelic mutation actually do localize to this BZIP region. But really, if you tease them out, the good prognosis is restricted to patients that have the mutation in the BZIP region. The WHO still retains the biallelic variant as well. The ICC only recognizes the BZIP mutated cases. Similarly for ELN, only in-frame BZIP mutations are categorized as favorable risk. Okay, AML with mutated TP53. As I told you, it's recognized as a distinct entity in the ICC and ELN, but not in the WHO. In the WHO, the majority of these cases are classified as myelodysplasia-related AML by virtue of their complex karyotype. As you know, most TP53 mutated AMLs have complex karyotype. But let's look at the classification of these neoplasms. So if you have MDS with 0 to 9% blast, multi-hit TP53, then you have MDS with TP53 mutation. MDS/AML with mutated TP53 is 10 to 19% blast. Here, the allelic status doesn't matter. So once you have more than 10% blast, even if you have just one mutation with a variant allele frequency of 10%, that's sufficient. And then obviously AML is more than 20% blast. Again, any one somatic mutation qualifies as long as it has a VAF of more than 10%. And the VAF 10% cutoff here really was used to avoid including cases of clonal hematopoiesis that are TP53 mutated, but not necessarily the driver of the disease. Okay, how about the VAF of TP53? Does it matter or not? This is a study that was actually done by my colleagues at MD Anderson, where they looked at newly diagnosed AML patients with TP53 mutation. When we use the 40% VAF cutoff in these patients, in the patients that were treated with intensive chemo regimens, the 40% was prognostic. However, in HMA-treated patients, hypomethylating low-intensity regimens, there was no prognostic value to the variant allele frequency. Now, I told you a lot about the allelic status of TP53 and MDS and how it's been incorporated into the classification and how it's not yet incorporated for AML, right? But since then, and after the classifications, there are studies that have been published, including this very nice paper from the German group in Blood Advances, where they look at both AML and MDS, obviously to look at the prognostic value of the allelic status of TP53. And MDS, it, of course, it's validated, it corroborates with previous findings, no problem. In AML, though, they also show that the majority of patients with AML have double hit status, right? So either double mutation, copy neutral, loss of heterozygosity, or more than 2 mutations. And in fact, the overall survival for double hit is significantly different from single hit. So 1 month versus 8 months. So it shows you that there's actually prognostic value in the setting of AML as well. So again, in some instances, TP53 may not be as prognostically relevant. I really like this Venn diagram that they did here. You know, there are neoplasms where TP53 is frequent, and we know it has prognostic influence, like MDS, therapy-related AML. There's this borderline category where it's not as relevant and it's not as frequent. And then in the setting of, let's say core binding factor, AML with PML-RARA, NPM1 mutation, it may not be prognostic. And, there are just too few cases to know for now. But I'll show you this one example. This is a case that I had in my practice. So this is a patient with newly diagnosed AML. We do NPM1 IHC and P53 IHC on all of our newly diagnosed cases. Again, NPM1 IHC being a very good surrogate marker for the mutation. When you see cytoplasmic staining, which is an abnormal pattern of staining, it almost always correlates with the presence of a mutation. Very rare cases that I've seen that did not have a mutation actually had an NPM1 translocation. So the exact same region, right? Look at the vessel that's going here. So you know that this is the same area, same neoplasm, and it has this increased expression of P53. And to be honest with you, when I saw this case the day I was making a diagnosis, I was very hesitant because typically we know that P53 and NPM1 don't co-occur. So I was kind of skeptical that this was real. And I said the P53 was inconclusive in my report. But then sure enough, the NGS came back and there is a P53 mutation with a variant allele frequency of 89%. And there's an NPM1 mutation, of course. This patient very rapidly deteriorated and died. But so in classification, this is still considered NPM1 mutated AML because in the classification system, NPM1 trumps everything. But in terms of risk stratification, if you look at ELN, because there's a complex karyotype, this is still considered adverse risk. Okay, how about post-cytotoxic therapy, or what we used to call therapy-related myeloid neoplasms? So the WHO still recognizes these as a distinct category that trumps, everything else. So they say you should say what the genetics are, but you should still also include that this is therapy-related or post-cytotoxic therapy. The ICC has really kind of de-emphasized the therapy-relatedness with emphasizing the genetics. So therapy, you can use it as a qualifier, but you should really classify based on the genetics in the ICC. And here's an example. This is an erythroid leukemia, CD71 positive, ECAD heron positive, P53 again mutated, and you can see the dysplasia, the dysplastic megakaryocyte here. And so, in terms of the WHO, why do they think it's, it's important to say that it's therapy related? So here's one study published in 2023 in Blood, looking at TP53 status in therapy-related myeloid neoplasms. So here, the allelic status of TP53 really doesn't seem to be as important. The multi-hit patients and the single-hit patients really do the same. The only thing that in this study, in the setting of therapy-related myeloid neoplasms, was prognostic was a 10% variant allele frequency of the TP53. So if you had a clonal burden that was less than 10%, then those patients did better, similar to wild type. But if you had anything more than 10%, may it be multi-hit or single hit, then those patients did really poorly. And then there's this one paper in Blood that was, this is an abstract that was presented at ASH 22, where they did some fancy, bioinformatic type AI-driven modeling, and they came out with a VAF cutoff of 23% that was prognostic and predictive of a multi-hit status in the setting of AML, right? So again, this is to be further validated, I think, but just know that the cutoff may be lower than the 50% that we're using. All right, so myelodysplasia-related AML, really the major change that is implemented in both the classifications is the omission of morphologic dysplasia as a criterion. So you no longer qualify for AML-MR with morphologic dysplasia, and the inclusion of MR-defining mutations. So let's talk about these. So the karyotypic abnormalities are pretty much the same between the two classifications. ICC also recognizes trisomy 8 and del20q, the WHO doesn't. The somatic mutations are the splicing factor mutations, ASXL1, BCOR, and then EZH2, and again, the splice mutations. The ICC also includes RUNX1, the WHO doesn't. In practice, this is not as much of a problem because RUNX1 seldom occurs in isolation or is mutated in isolation. It typically co-occurs with another MR type mutation. So the majority of these cases are classified as, the same in both classifications. Importantly, neither of the classification systems enforces a variant allele frequency cutoff for these mutations. So right now, any mutation qualifies, but I think you'll see that this is going to change in future iterations. Okay, so let's look at another classification dilemma, this time AML. 70-year-old woman with fatigue and shortness of breath. White BC is 2.2. There's neutropenia, anemia, and thrombocytopenia, borderline thrombocytopenia. So in the bone marrow, we see some erythroid predominance, multilineage dysplasia with occasional blasts. So let's say in the range of 5%. Here's the karyotype showing you the presence of inversion 3 and actually monosomy 7. So the fish is showing the inversion 3 with separation. This is a break apart probe showing the separation of the green and red signals. So based on the 5% blast, by WHO, this is AML with MECOM rearrangement. And by ICC, it's MDS still, because it doesn't meet the 10% requirement, right? Again, I think risk stratification-wise, this is still important because, again, you want to plan for next steps. You want to see if you have to transplant the patient or not. But again, something to think about in terms of how and what scenarios sometimes the classifications may be discrepant. In terms of risk stratification, again, largely based on the genetics, some of the changes that I'll just go over the most significant changes that were implemented in EL in 2022 compared to 2017. So the allelic ratio of FLT3 is no longer important. That was omitted. Any FLT3 mutation qualifies for an intermediate risk. Myelodysplasia mutations were included as adverse risk. We talked about these. Adverse risk cytogenetics plus an NPM1 mutation is now considered adverse. As we said, these ZIP mutations are the only ones that are considered favorable risk for CEBPA. And then there are a couple of other translocations that are included in the adverse risk, including MECOM and KAT6A and CREB-BP. And then hyperdiploid karyotypes are not considered complex or adverse risk. And then if you don't have any of these genetic abnormalities in the WHO, your AML by differentiation in the ICC are considered AML-NOS. I think it is important, particularly for monocytic erythroid and megakaryoblast leukemias, to denote the differentiation, because we know that some of these patients, this is an example of an erythroid leukemia. Again, in the WHO, erythroid leukemia trumps MR-related AML. However, in ICC, this would be lumped into all TP53 mutated AMLs because we know that the majority of these cases have TP53 mutations. However, we know that these patients, even though TP53 is resistant to venetoclax, we know that patients with erythroid differentiation or megakaryocytic differentiation do even more poorly with venetoclax, or even more resistant to venetoclax because they have BCL-XL dependency. So again, as far as I'm concerned, it is important to denote in the report that there is erythroid, monocytic, or megakaryoblast differentiation. So again, most significant changes to the WHO and ICC. I think, we reviewed everything in terms of myelodysplastic syndromes and AML, but let's just, summarize. So for MDS, it's the creation of additional genetically defined categories of biallelic TP53 and SF3B1, and then creation of a novel morphologic category, hypoplastic MDS and MDS with fibrosis. Optional designation of unilineage versus multilineage dysplasia. I forgot to mention this. but the WHO no longer requires, this is, optional to say whether the dysplasia is unilineage versus multilineage. And then, of course, the change in the nomenclature from dysplasia to neoplasm and from excess blasts to increased blasts. And then in the ICC, you have the creation of MDS/AML for the 10 to 19% blast category. And then for the AML, most significant changes to AML in the WHO and ICC. So a couple of new AML defining rearrangements, right? So KMT2A, MECOM, and NUP98 are now AML defining. NPM1 mutation, similar in both classifications as AML defining with variable blast cutoff. The CEBPA mutations are only considered AML defining in ICC. WHO still requires 20% blast. We talked about CEBPA mutation and the restriction to VZIP region. AML myelodysplasia related, again, omission of morphologic dysplasia and inclusion of somatic mutations. And then myeloid neoplasms with TP53, again, we talked about this, only ICC recognizes MDS/AML and AML as a distinct category, not WHO. And with that, I thank you for your attention, and I'm happy to take your questions.
Thank you so much, Dr. Sanam, for such a lucid talk and such an elaborative discussion.
My pleasure.
Yes. So, Dr. Sanam, we had shared certain questions with you, and can we discuss on those lines?
Sure, of course. Go ahead. Would you like to read the questions or?
Yeah, I will read the questions.
Okay.
For you to read, Dr. Asta, wow, it was like very extensive on TP53. Dr. Sanam will be coming back. Me, Sridhar, and Asta are going to take your inputs on TP53 mutation because that's what our area of interest as well. So great.
Right.
Wonderful. Dr. Asta, please.
Yes. So, we know that genetics have been totally incorporated into the classification, but in the presence of cytopenia, if there is no single morphological dysplasia, then how to formulate our morphology reports with certain comments, or you wait for the NGS to be back and then incorporate everything together and make the diagnosis?
Yeah, I think so. In reality and practically, I think there is really no point in making a definitive diagnosis without genetics at this point, right? So what I tend to do, I'll just describe for you my typical workup of an MDS. Obviously, the first day that I get the case, I don't have knowledge of the genetics, right? So I rely heavily on the cytopenias, on morphology, and of course, on flow cytometry as well. I think we have the advantage of doing flow cytometry and looking for aberrancies in the myeloid blast. That is very helpful to me. I find that very helpful. If I have a case with profound dysplasia, but the flow looks completely normal, I'm going to be very cautious. And, I'm going to try and exclude vitamin deficiencies or things like that. But if I have dysplasia and I have more flow cytometric aberrancy, then I feel pretty comfortable that this is MDS. So I will, in my diagnosis top line, say that this is myelodysplastic syndrome or myelodysplastic neoplasm. And then I say that, the genetics are pending and I'm going to issue the final classification once the genetics are out. Because, this can be TP53 mutated. Of course, I can do the IHC. That will be helpful, but I won't know the allelic status just based on the IHC, right? So I need the karyotype. I need the NGS. So our clinicians are perfectly fine with that, because really they just need to know the patient has MDS to try to start working the patient up, getting approval for hypomethylating agents and things like that. But really, they don't need a specific subclassification to start, their treatment planning. Of course, now if it comes back as a TP53 mutated case, they may go to refer the patient for transplant. But again, I think there's no urgency in that. You can wait for the NGS. Now, if you don't have NGS, then that's another story. Then you have to, you use the best tools that are at your disposal. Then you use P53 IHC. If there's increased blast, I would always recommend doing an NPM1 IHC because you could have, low blast NPM1 and things like that. But again, I think the best practice to me is to issue a preliminary diagnosis and say, this is MDS. I think this is MDS. And then the final diagnosis should incorporate all of the genetic parameters.
Okay. So while we are discussing about the IHC for TP53 and NPM1, so you said about optimization on bone marrow. Yes. So when we 1 plus, 2 plus, how do we define this as 1 plus or 2 plus? And secondly, when we have a infiltration of the marrow by blast, there will be normal cells as well. So
Yes.
looking at the positivity in blast only or along with that in the normal maturing cells, basically not normal, but maturing
Yeah, yeah.
cells. So how do we actually quantify our IHC positivity?
Right. So I think, the 1 plus, 2 plus, 3 plus, you have to look at the cases and you'll see it. You'll see the variation, right? So the 3 plus is very dark nuclear staining. So I would recommend for your positive control, you use, a known TP53 mutated case, and that's going to be your positive control that shows you the 3 plus type of staining, right? And then 2 plus is kind of intermediate, 1 plus is very faint, and obviously absent is just 0, right? So in terms of what you count, I count any 3 plus. So oftentimes you'll see that there is 3 plus staining in erythroid cells. Typically, there's no 3 plus staining in the maturing cells because they're not proliferating. So the TP53 level also kind of correlates with the proliferative potential of the cell. So you will see that the majority of the cells that show intense staining are mononuclear cells. But sometimes you do see it in megakaryocytes, and sometimes you do see it in maturing cells. I would count any 3 plus staining. It doesn't matter what type of cell it's.
Okay. Taking one question from the audience. Is translocation 821 a good prognostic marker in the era of NGS? And which coexisting mutations have an adverse prognostic impact in 821 mutated patients?
Yeah, so 821 is still considered favorable risk. In fact, if you look at ELN22, so previously we used to think that KIT mutations had, patients with 821 and KIT mutations had worse prognosis. But now if you look at ELN 2022, KIT has been removed as an adverse prognostic indicator, largely because of the recognition of the impact of MRD monitoring. So if a patient, even if they have KIT mutation at baseline, if their PCR for 821 becomes negative and their MRD negative, they tend to actually have a good outcome. So really the MRD status is more important than the KIT status at baseline. So 821 is still considered favorable risk.
Okay. Another one, so significance of OR-ROD in MDS with increased blast. WHO mentions it, but ICC doesn't mention about the OR-ROD presence or absence. So still we consider presence of OR-ROD as an excess blast, increased blast too, or?
Yeah, but remember, ICC doesn't have MDS excess blast 2 anymore. So that is the thing you want to consider. Yes, so our rods are excess blast 2. But that would push the case into an MDS/AML for ICC.
Correct. So if there is an OR-ROD with 6-7% blast, then it will be pushed into MDS AML according to ICC.
Yes. Yeah.
Right. And if there is a patient of cytopenia, like thrombocytopenia or pancytopenia with the TP53 mutation, but the variant allele frequency is of 5 to 10%, like less than 10%, how do we classify such patients and how do we incorporate this TP53 into our practice? And some of these patients who have isolated thrombocytopenia are also steroid responsive. So how do you see these patients in your clinical practice?
Yeah, so I would say if you have a TP53 mutation, that's less than 10% variant allele frequency. And obviously, I think we're talking about cases that don't have increased blast, right? So if you have increased blast, that's a different story. If it's less than 10% variant allele frequency, you have to be very cautious because that could be just clonal hematopoiesis, right? With that said, I would advise to you that this has to be in the setting of a good aspirate, right? If you have a fibrotic marrow that doesn't have a good aspirate and your variant allele frequency is low, that is not a reliable parameter, and you should still do the IHC because remember, if the patient is profoundly neutropenic and you're only sequencing a very hemodilute aspirate smear that has only lymphocytes, you're not going to get good representation of the mutation. So your variant allele frequency may be falsely decreased or low, right? But the actual clonal burden of the P53 mutation may be high in the bone marrow. But if really, truly, that you have a good sample and the variant allele frequency is less than 10%, then that may be clonal hematopoiesis, and you don't want to overinterpret that finding.
Okay. Okay. One question from the audience, that how does both the classification have a significance in determining the treatment?
Yeah, so in reality, I think it doesn't matter what we call things, right, on a report. Really, it matters what type of genetic driver there is and how those genetics drive treatment. For MDS, really the only therapy that we have right now in the frontline, well, now we got a couple more FDA-approved agents, but really think about, in general, is hypomethylating agents. And these are mutation agnostic, right? It doesn't matter what type of mutation you have. It doesn't matter what you call it. If the patient is transfusion dependent and they have MDS, they get hypomethylating agents. In terms of risk stratification, I think the genetics and the classification and risk stratification, like the examples that I showed you, matter, because at least in the United States, to get a patient to transplant, you need to plan extensively. You need to identify a donor. You need to get insurance clearance. Sometimes it costs over $1 million to get a patient to transplant, right? So, and let's say TP53 mutated MDS qualifies for a transplant, whereas SF3B1 mutated MDS doesn't qualify for a transplant. So I think, it's important in treatment planning, but really at this time, there are no mutation-targeted therapies in MDS.
So, Dr.
For
Sanam, I have
AML,
a question.
it's different. Right, go ahead.
So, Dr. Sanam, how about the co-mutation? So, NPM1 comes with KRAS, NRAS, SF3B1 comes with the STAT5 or NRAS mutation or a KIT mutation. So, do you think that in the further classification, the co-mutation status will have an impact that the multiple mutation which keeps on coming will have a prognostic score which can tell us whether to transplant or not to transplant? In myeloid myeloplasms, as a clinician, the only thing is, should I only give chemo or should I give chemo plus transplant? And that's the only idea within the NGS what we are doing. I mean, you might be interested, Asta might be interested, Srinidhi might be interested in 10% VAF or 12% VAF, but cytopenia and TP53 of 9% VAF, and he's a young guy, I would transplant them, isn't it? And in India, it's an open country, so people will get a transplant done. So for me, how does this co-mutation which exists together needs to be tackled? And what's the future for them?
You'll see there are extensive studies, including some that we've presented at ASH, and hopefully you'll see soon in publication. The co-mutation status, of course, matters, but it depends again on the mutation. So, for instance, in NPM1 mutated AML, the presence of a RAS mutation doesn't seem to be as significant. Whereas I think if you look particularly in younger patients, although these mutations are not enriched in younger patients, but we've looked in our own data and the UK NCRI data database, we've looked at patients that have NPM1 mutated AML with co-occurring MR type mutations. And these patients do actually, there's conflicting data. There are some publications that say they don't. But if you actually look at the younger patients, they do have inferior outcomes. So those patients may actually benefit from, hematopoietic stem cell transplantation. Again, there's a lot of nuances and intricacies. What is the clonal burden of the MR mutation? How high is the variant allele frequency? I think it's very complicated. And that's why, hopefully these calculators are going to get better and better as time goes by. But if you look at the IPSS-M, right now, it accounts for co-mutations. It accounts for the number. It's not the specific, risk of, let's say, a certain mutation, but the number of mutation, the type of mutation is accounted for. And I think so for MDS, and there's a paper that's just recently published in JCO by Dr. Della Porta, Dr. Kamrakchi, and their group, where they show that the IPSS-M is robustly prognostic in predicting who benefits from early transplant, right? For AML, I think it's still, front line. I think MRD is probably more important in the setting of NPM1 than it is the presence of the co-mutations. So you want to induce the patient, you want to follow their MRD. For the patients that don't clear their NPM1 with a sensitive, ultra sensitive, so we're talking 10 to the minus 5, 10 to the minus 6 MRD assay, that patient needs a transplant, right? It doesn't matter what their co-mutation status was. It doesn't matter if they had a FLT3 or if they didn't have a FLT3. If they don't clear the NPM1, they need a transplant. So I think it's going to depend on the various subtypes. And again, we need kind of more sophisticated calculators. But there's really no one logic that can be applied to every patient. I think the moral of the story here is that this is a patient by patient base, right? And there should be really good communication between me, the pathologist, and you, the clinician, in really determining who are the patient, because transplant is not trivial, right? There's transplant related mortality risk that is not trivial. So I think it's important to really identify the patients that we think are truly going to benefit from a transplant.
So before Asta shoots another question and Srinidhi comes in a genetically inspired leukemia treatment, now we have a machine on GenX which can give us the NGS report in 3 days. Does your classification actually brings in and writes the death sentence for 7+3 and over based on as or when based on your classification, or you just like to go still very conventional?
So to answer your question, so I'll say two things. One is we never make treatment recommendations in a pathology report because we're not, as a pathologist, I don't think I'm qualified to make a treatment recommendation, right? I can tell the oncologist the diagnosis, the genetics, everything, every piece of information that they need in order to determine the best therapy for the patient. The other thing is, so right now at MD Anderson, we do not use 7+3 at all. So we have high intensity regimens like FLAG-IDA-VEN, FLAG-IDA, but we don't use 7+3 at all. We, obviously we use HMA-VEN, low intensity, sometimes in triplet with, FLT3 inhibitors if the patients have FLT3 mutations. But the decision of whether to use a high intensity therapy or a low intensity therapy is not just based on the genetics. It largely depends on the patient's performance status, their age, their, again, like their baseline status. So I think I can provide the information that can help the clinician decide what type of therapy they're going to use, but I would never make a recommendation of how to treat the patient.
Okay. There are many questions coming in. So, does the morphology of blast predict any kind of genetic abnormality? As we know, like in NPM1, those cup-shaped nucleus and all, have there been any more of such findings in your practice that you can share us with?
There's some, right? I mean, none of this is, I think, foolproof. But again, usually from the morphology, we can predict SF3B1 mutations by the presence of ring sideroblast, right? And just the profound erythroid dysplasia. Typically monoblastic leukemias with very high white cell counts, maybe KMT2A rearranged, we know that. Deletion 5q has the characteristic small monolobated megakaryocytes. Inversion 3 typically has characteristic findings like an elevated platelet count. It can have the micromegakaryocytes. So there are, underlying morphological clues, but none of this is gold standard, right? Even let's say with the cup-like blasts, everything. If I want to put if my clinical colleagues want to put the patient on a menin inhibitor, they're not going to rely on me saying, oh, there's cup-like blasts. They want to know that there's an NPM1 mutation, right? But of course, there's things that we can use to say, predict with relatively good confidence that there's an underlying genetic abnormality.
Okay. 5 more minutes. So role of IDH mutation in risk stratification of AML as of now? What is that?
Yeah, so there's no role in stratification at all. So and IDH
NPM1 also? With NPM1, IDH1, somehow it has like become a Donald Trump not leaving the chair. Similarly, in our cohort, the NPM1 tends to go away without IDH1. So IDH1 is always along with NPM1. How do you say that?
No, it's not always. It's frequently, but it's not always. But so there's no role in risk stratification for IDH. But of course, IDH, at least in the United States, IDH1 and IDH2 mutations have approved targeted therapies. So it's actually incredibly important for us to detect the mutation because then the patient qualifies for IDH inhibitors.
Okay. Can you please just, ma'am, elaborate on disparity between IHC for TP53 and the mutation detection of TP53? Like in most of your cases, you have found that TP53 IHC is positive and it correlates with the molecular part.
Yes.
But if there is a disparity, when and what can be?
Yeah, so there's three caveats that I would highlight for you. One is the one that I showed you. When there's signaling mutations, you can have upregulation of P53. It's usually in the range of 2+, and you'll see it in a lot of cells, but that's wild type. The other is if you have a very low VAF P53. Again, remember, the IHC is only picking up the P53 mutated cells. So if your variant allele frequency is 10%, 5%, you may not be able to detect it reliably by IHC. The other one is inverse. So you may actually pick up some cases by IHC that you don't see by NGS because there may be, so first of all, you may not have adequate coverage in some regions on TP53 and NGS. The other is pre-analytical issues like sample adequacy. So again, if you have a hemodilute sample, if you don't have good representation of the hematopoietic stem cell or myeloid compartment, you may get a false negative NGS result, but you may see IHC staining that is positive in 3+.
Okay. Okay. And yes, I think we have covered most of the questions. With respect to NPM1, all we have discussed.
Dr. Srinidhi, do you have any questions?
I have, I guess I have loads and loads of questions, but then I think we don't have.
You have to unmute yourself, Dr.
You are
Srinidhi.
muted, Dr. Srinidhi.
Oops. Hi. So I have actually got a lot of questions in my head, but then right now I don't think we don't have so much of time. So some questions I'll just, probably email and clear my doubts. But one thing is, are all FLT3 and are all TP53 created equal? Because we do see that some TP53 mutations, although almost all missense mutations are pathogenic, but there are some which tend to be pathogenic in the West. And we see that in our population, we get it in like 80 to 90% individuals. And we don't really report that as, like, for example, the P72R. We don't report that on the report because even normal individuals. In fact, once when I sequenced my own, and I also had that P72R. So, how is it, how much difference does it make? Because so that is one thing for TP53. Second is core binding leukemias, everywhere, we've been taught since the time we did pathology that it's favorable risk. But in our cohort, even at the center where I trained for molecular hemonc, the core binding leukemias didn't really do great. And right now also we see that, they come back with relapses, including extramedullary relapse and, very late relapses. And the KIT mutation, it's like, you get some cases which are flow MRD negative but NGS positive. You also get flow MRD positive, sometimes NGS negative. But then, so again, like, what do you do with TP53 mutated cases? Because TP53, although now has been allowed as an MRD marker, but not a very great marker like ASX cells also. And so what is a good strategy? Because in an indigenous setting, like in a setting like India, where there is a lot of economical restraint, I cannot do NGS MRD for the patients every time we do a bone marrow. So, maybe does it help that we do a, NPM1 just like how we do on a digital PCR or a real-time PCR? Will doing a KIT mutation on a digital PCR help, monitoring that, because the cost comes down and the sensitivity still remains? So it holds good. And how can we have a local solution to this kind of a problem? So because I want to devise a strategy which is, fits to our patients and not really very oriented to the guideline, because I need to devise a solution which is patient friendly as well. And the other question
for the TP53 mutations, I'll answer that first. So of course, not all of them are created equally. We also don't report SNPs and polymorphism. We don't report them as pathogenic. I would say if you have doubt whether something is pathogenic or not, this is actually a very good setting to use in IHC. So most pathogenic mutations will actually show the abnormal IHC pattern, and the SNPs and polymorphisms will not. They will look normal. So that actually IHC can be very helpful there. In terms of the core binding factor leukemias, again, I think that the MR. So remember, I think the treatment setting is also important, right? So when we're talking about the favorable impact of core binding factor leukemias, we're talking about resource wealthy settings where the patients are treated in protected environments. And so that may be a factor. The other thing is, as I highlighted, MRD, the status of MRD is important. If the patients remain MRD positive, then they are not considered favorable risk and they get trumped into intermediate risk, right? So that's the other thing. In terms of molecular versus flow cytometry, really right now, the only approved molecular markers for MRD are the core binding factor leukemias, APL, NPM1. FLT3 is not yet in ELN, but I think it will be incorporated based on the recent studies that we've seen. But TP53 is not a marker of MRD. In fact, we know that oftentimes the patients clear their, well, not that they clear, but they clear the burden of disease. They still have low-level MRD, but they may have a huge TP53 mutation left. So P53 definitely is not a good marker of MRD. I would not use it as an MRD marker. I think outside of the setting of the recommended markers of MRD, flow cytometry is still more powerful and robust in predicting outcome than molecular, because you can have, residual clonal hematopoiesis, if you will, in a lot of these AMLs, including the MR type AMLs, that doesn't necessarily represent residual leukemia.
Okay. So one last question. We have two cases where bone marrow shows less than 1% blast, cytopenias. Patient came with NPM1 positivity with high VAF. How do we classify these cases? Straight away gone into AML?
No increase in blasts?
No increase in blast.
Yeah, so that's tricky, but I think, in my mind, if there's NPM1 high VAF mutation, this is AML. Even though, the classifications say, and I have to tell you, we dwelled over this a lot. And, the idea is to be more conservative because you don't want to overtreat the patients. But, I've seen this in front of my eyes where the patient had a marrow done at an outside institution with less than 5% blast and an NPM1 mutation. They were referred to us in a matter of like a week or two. By the time we did the bone marrow, the patient had 80% blasts. So these are going to evolve very rapidly. It's just a matter of time. If you have a high, I'm not talking about low VAF NPM1 mutation. So low VAF NPM1 mutation is ultimately going to expand as well, but it may just take more time. But I think for high VAF mutation, really, we need to also use our judgment, right? If the patient's cytopenic, they have a high VAF mutation, that patient, in my mind, NPM1, NUP98, MLL, KMT, these are AML defining. This patient is going to rapidly evolve. So I think, I would say, even though that the patient doesn't qualify, this may be AML in evolution, something to give the clinician the kind of authority to treat the patient as AML.
Right. Okay. So
can I ask one last question?
Okay.
So we had this patient who had a very complex karyotype. They transplanted the patient, but he continued to have that complex karyotype. And there were some more random, changes in the karyotype, which were there for one bone marrow, and then they disappeared again in the next follow-up. So now what do we do for this patient? How do we interpret this? Because the chimerism is 100%. And the bone marrow after transplant is still showing a very complex karyotype.
But so chimerism is not 100%, but the bone marrow is still showing a very complex karyotype. In how many metaphases?
In 20.
In 20 metaphases.
And the abnormality is seen in 4 to 5 metaphases. The study was done on 20 metaphases. And the same karyotypic abnormalities which were present pre-transplant are there with some more additional random changes.
Yeah, that patient is going to relapse. So chimerism is not 100%. If they have the same abnormalities in 4 to 5 metaphases, that patient is it's just a matter of time.
Yeah, so we are still dealing with all these problems, Dr. Sanam. We transplanted a patient who was WT1 and KIT mutation, good VAF, 45%, did well for 2 years, and there was a small clone FLT3. Now he relapsed isolatedly in CSF after 2.5 years.
Yeah.
Yes. So
Yeah,
c-KIT
we've
mutation
seen this
continues
often
to
as
be.
well, the extramedullary relapse in patients, that are transplanted. Obviously, it still remains a challenge, and even with our best therapies in the best settings, AML survival is still not great. So, and like even the favorable risk, like outside of core binding factor, NPM1, whatever, really, it still remains a challenging disease.
And I think that's what, Dr. Sanam, we come to an end of today's webinar, and which leaves us a taste that we need to collaborate more, and different mutation needs to be seen through different genetic populations. So we have the luxury, you have the luxury of seeing the Caucasians. We also have the luxury of seeing the Middle East, as well as the Southeast Asia, and as well as Africa and Indian origin. So one day, if you have the sufficient numbers, we would like to collaborate with Srinidhi and you and Dr. Asta, talking about the variants of TP53 in various mutations, and trying to do a single cell analysis of understanding what can lead to a TP53 mutation and FLT3. It's just that we don't know. That's why this chaos seems so random. But in this cosmic chaos, there has to be some order which we don't know, but we'll surely know one day. So with these thoughts, thanks, Dr. Sanam, for wonderfully elucidating what is new in ICC and WHO. So there are break apart genes which you have created between WHO and ICC. But it's so wonderful to listen. And all the 500 participants who has joined in and stay hooked till this 1 hour and 15 minutes. Thank you all for your interest into this evolving field of hematology, with a promise that at Fortis Institute of Hematology and Bone Marrow and Bone Marrow Transplants, we will deliver the solutions which will save many more lives in the future. Along with MD Anderson support, MD Anderson has been very, very special to us, Dr. Sanam, to tell you. A lot of Indians are there, from
Right.
Nitin Jain to Jayastu, and all of them have always extended their helping hand to develop science in this part and rest of the world. So again, thanks a lot for Dr. Asta for taking out your time. You're a brilliant hematopathologist doing a wonderful job, Dr. Srinidhi, and to entire colleagues. Thank you.
Thank you very much for having me, and thank you to the audience for tuning in. I really, really appreciate being here. Thank you.
Thank you, Dr. Sanam Logavi. Thank you, Emcure team. Thank you, everyone. Good night.
Good night. Thank you.